So I want to talk a little bit about some work we're doing in terms of a classification criteria project, both the current Discoid lupus classification criteria set and where we might go next with it. And then really, I think the point of the focus of this was an overview of the current treatment approaches. So I really try to focus mostly on therapeutics, but I think some of where we're headed has a lot to do with what tools we have to try to get there. And without some of the early work like classification criteria and other outcome measures, it makes it a challenge to go on and move the field forward. And Vicky knows this all too well. So I'm going to start there. And so I'm actually quite pleased to tell you that this is a work in progress that will hopefully be done relatively soon. We several years back had a pre-Delphi and consensus meeting that occurred in Scotland many years ago now, at which a group of sort of international experts came together and decided that a single classification scheme was needed to meet the needs of researchers and stakeholders. And we took a lot of data out of that meeting, including a variety of input on items that might define skin lupus, that might define different subsets of skin lupus, and ultimately decided that our first proof of concept dive into the deep end here would be to focus on discoid lupus specifically. And you know what's really interesting is if we look at this picture, you know, it's really a challenge. I think for the dermatologists in the room, your eye immediately starts to build a differential, and you know, I think I can say that discoid lupus, you know, chronic cutaneous lupus of the discoid variant here comes to the top of the list quite quickly for the trained eye, although there certainly is always a differential diagnosis to be thought of. For the rheumatologist, this might also come to mind, but there may be some other things that come into your mind. And the challenge was stepping back and saying, well, why? You know, why is this discoid lupus, and what are the features that make it specifically discoid lupus and not something else? And I still struggle with it. I think it's still a challenge in some ways. And what's interesting is, as I've learned more about artificial intelligence and how you program a computer to think in this way, you know, we really have to start to deconstruct every little aspect and ask ourselves why. And what's interesting about this is ultimately, I'd like to say we did that. We took a lot of different items, and we did an international Delphi consensus process with several hundred people, and we came up with this that was published in the JAD, which was the first set of items that will go on to our current work, which is looking at a formal build of a classification criteria set. Some of the items that came out of this Delphi process, and we started with over 50 different items, 12 of them remain in the end, were based on morphology. You can see here erythematous violaceous color, scarring, dyspigmentation, etc. Some histopathology findings, including an interface dermatitis, and location. And so this is an ongoing work. Hopefully we'll have something more to present on this, and we're hoping that this will also inform how we proceed with sort of a broader cutaneous lupus classification criteria set that ultimately help inform, I think, trials and observational work that still needs to be done in the field. What about challenges? And this is something, so Vicky and I were quite literally just talking about this in the room next door. There are, you know, challenges to drug development programs. So you said, why don't we have, you know, when I think about my psoriasis world, I have, you know, a laundry list of therapeutics to talk about and to offer, but it's much less so. Particularly from an FDA-approved list of therapeutics, much lower in my, you know, systemic lupus or my skin lupus clinic. And there are a variety of reasons for that and challenges. And one of the challenges, trying to decide whether a program from a drug development standpoint focuses on unique subsets. Do they just focus on discoid lupus, or do they focus on skin lupus broadly? And then there's the issue that Vicky always brings up of how many of our patients overlap and really don't fit into one category. There's been a focus historically on systemic disease using systemic lupus outcome measures that don't include a skin-focused endpoint. And this is where Vicky's development of the CLE outcome measure has really been crucially important, but at the same time has not necessarily been taken up into a lot of drug development programs, at least as of yet, and hopefully that will change. Another point that I think, you know, needs discussion is how patient-reported outcomes fare when we talk about discoid lupus and we talk about other lupus subsets and we talk about how it fits with the bigger picture and the fact that there is no currently FDA acceptable outcome measure. And I use this picture just to point out that, an assessor activity measure may actually say, many of us would feel, I think clinicians would feel quite proud of ourselves when this patient, this was a publication, picture I stole from a publication, but I think does it justice. If we turned this patient into this patient, I think many of us would feel quite good about ourselves. I think we'd say, look at this great success I've had. At the same time, it's very patient specific how the patient themselves feels about this, because there is a lot of scarring and damage. And I can tell you from my psoriasis world, when we get people clear, they're clear, right? Except for maybe some dyspigmentation, but there is quite a bit of scarring here. And how does this turn out? What does this look like in terms of the sensitivity to change of a patient-reported outcome, for example? I think that still needs to be determined. It sounds like from talking to Vicky that this is something they're actively working on. I think that's important. And then what do our outcome measures look like for drug trials? And we really don't have necessarily the tools that the FDA wants. I think we could argue that Vicky has made the tool that that certainly should be used in this category, but there's a lot of discussion about how do we move the field forward, what sort of outcome measures do we need. So with that as a caveat, I will move into our current treatment approaches and talk to you about how the field is starting to move forward despite some of those challenges. But those challenges also offer a lot of opportunity because it gives us the opportunity as the experts, and that's everyone in the room, seeing these patients, to start to bridge those gaps and think about changing our field and getting new therapies. So the current treatment approach is, and this is just my humble attempt at a little bit of what we do in our clinic, and again, Vicky can feel free to jump in if I've completely destroyed something. But in terms of really first-line therapies, I think for most of our patients, it's pretty easy, and we're pretty all comfortable talking about aggressive photoprotection, talking about smoking cessation, all of the things that are certainly going to help, in the baseline state. Depending on how widespread their disease is, depending on what the etiology is, this is really a very broad brushstroke. Of course, if we're talking about one lesion versus widespread generalized discoid, these are going to vary. But in general, we're going to reach in our arsenal for topical steroids, perhaps intralesional steroids for a few scarring scalp lesions, for example. Potentially put out the fire briefly with systemic steroids, although we're almost certainly trying to avoid those in the long term. Use of topical calcineurin inhibitors, particularly in sensitive areas such as the face. And then the classic anti-malarial march. And I always love talking, putting my rheumatology hat on and seeing the rheumatologist's face when I bring up the anti-malarial march, because this is something I certainly learned. I learned from my mentors, Andy Franks and Vicky and others over the years, and this is sort of burned into our treatment paradigm in derm. But the rheumatologists sort of roll their eyes and say, "What are you talking about?" And so in dermatology, we're always taught to start with hydroxychloroquine. If they've had some success but incomplete, thinking about adding quinacrine or changing to chloroquine or doing other combinations. And I'll show you some of the limited data for this, but this is something that we certainly do routinely and find benefit in our patients. And then second, what I call second line, we're often thinking about methotrexate, mycophenolate. You'll see, interestingly, less so azathioprine in skin disease, which is unique for our rheumatology colleagues. And then thinking about thalidomide, lenalidomide, I'll mention Benlysta and show you some of the data that was brought forth sort of post hoc about Benlysta in the skin. And then a variety of other things that I think aren't necessarily in our first or second line bucket, but we reach for depending on the situation. So it's really a broad brushstroke, and hopefully I can go into a little bit more detail. But no question that topicals, antimalarials are still very much a backbone of therapy before we're reaching for other things. Yeah, I think it's helpful, again, with the rheumatology hat on, to consider the whole patient. If it's a patient with systemic disease, however, we're certainly going to be thinking a little bit differently about what our first or second line agent, particularly second line agent, might be, depending on other manifestations of disease. So certainly if they have an inflammatory arthritis component, so-called even lupus or something in that camp, we might be thinking about methotrexate. If they have ongoing nephritis or ILD, we certainly might be thinking about mycophenolate if that were the case. We may have we might take a pause if they have a known hypercoagulable state or antiphospholipid antibody syndrome to be using thalidomide. and other scenarios. So I think, we do have to think about these patients in their whole context. But for the most part, the discussion here and what I'm moving forward with is a somewhat isolated skin view of lupus treatment. So this is a really nice publication from Vicky, just to underscore the point about which of these populations and subsets tend to be more refractory. And I think this is really, this is our clinical experience as well, that the generalized discoid lupus patient tends to be among the more refractory as opposed to, say, the subacute cutaneous lupus variant. And I should say and add on that this also, I think, speaks a little bit to where the unmet need might be. So in terms of responsiveness to therapy, this is a multi-center retrospective cohort study of 200 individuals with discoid lupus. You can see an adequate clinical response within the first 6 months was achieved by about less than half of individuals. Non-response, 42%. 20% of responders ultimately lost response to therapy, and 10% of non-responders responded within 2 years. Non-responders did respond within 2 years or with the re-challenge, only 10%. So again, just getting at that unmet need, that there is a reasonable amount of recalcitrant disease and loss of response in these patients, particularly the discoid patients. In terms of responsiveness, so this comes to that point about the combination therapy. So this was a study that looked at combination Plaquenil and quinacrine treatment, which achieved disease response in 60% of non-responders to Plaquenil monotherapy. And this somewhat backs our anti-malarial March concept. It's a very small study, but you'll see here that 5 of these individuals with discoid were treated with Plaquenil 2 to 400 milligrams per day. At least 2 months later, 55% were responders, and 65% of those non-responders responded to combination therapy with quinacrine. So just the idea that this addition or change or shift within the antimalarial class is often helpful. I'll just add also as a caveat that a non-serious allergies to Plaquenil, to hydroxychloroquine, can often be overcome by switching to chloroquine, surprisingly. We've had good experience switching to chloroquine in patients who have sort of non-serious allergy, morbilliform drug rash or otherwise with hydroxychloroquine that then do okay on chloroquine. This is another study that looked at blood concentration of hydroxychloroquine, and I think there are a few take-home points here. So if we look at the second point, so median blood levels of hydroxychloroquine were significantly higher in patients with complete remission compared to those with partial remission. So just suggesting that a blood level did correlate with efficacy, okay? That up to 10% of these patients had very low blood levels, and this was considered to be a group of patients who were really non-adherent. So even in the setting of a clinical trial study, 10% of the patients weren't taking their drug. So we know if we extrapolate that out to patients who are not in a controlled setting where they know someone's going to be checking their blood and talking to them, that our patients are probably not so compliant or as compliant as we think they are, and probably drive some of the disease that we see in the recalcitrant disease. And the conclusion being that monitoring blood concentrations might improve management of refractory disease. Related is a study that looked at, again, at Plaquenil levels and actually trying to increase the level above a certain threshold. You can see here. The endpoint was number of responders as defined by CLASI improvement of 4 points or 20% decrease, and that endpoint was defined by Vicky's group in the past. And you can see here the before and after intervention, and the statistically significant group that 81% of patients met their primary endpoint by doing this goal-directed concentration dosing. And so speaking again to the last point. So I think the take-home point there is, not all antimalarials are created equal, and combination therapy often makes sense in patients who are otherwise failing. Retinoids are something that we often forget about, I think, for some reason, and we've had a number of patients where we've reached for these in the right clinical setting, and one comes to mind in particular who had a palmoplantar keratoderma, as well as pretty decent localized discoid lupus, and actually derived double benefit from being on a systemic retinoid. But the point of this study, it's a bit of an older study, but showed that acitretin was comparable to Plaquenil in this study. And so, yeah, if there's the right clinical setting to use a systemic retinoid, it may make sense to think about in that context. So I think it's important to start to move to the second and third line therapy, given the number of often refractory cases in this, in this population. It's not uncommon that we have to think about second and third line treatment. So let's spend a minute on thalidomide. How many folks, just out of curiosity, how many folks write or are registered prescribers for thalidomide and or lenalidomide? Okay, so in case you're not aware, you do have to be a registered prescriber for this medication. It's not so scary. It's not that much different than, say, you're being an iPledge prescriber. So for the dermatologist in the room, it's sort of similar. It's actually quite a bit less burdensome, I think, than even iPledge, but with the burden on you of making sure that that there's no pregnancy, because it's certainly quite a scary medication in that to use in that population. So, so in terms of intervention, so this study looked at 100 milligram daily thalidomide, and I'll tell you, I often start at a little bit lower dose to see how patients tolerate it before going to 100, but that's just my practice. They defined a complete response as a CLASI of 0. It's quite dramatic. They demonstrated complete response in 92% of individuals with DLE. However, DLE was also found to have the highest tendency to relapse, almost 87% of these subjects, in comparison to other CLE subsets such as SCLE, on an average of 4.5 months. In terms of safety, about 20% of these subjects reported neurologic symptoms in the study, and there were a few vascular events among smokers in the group. I mean, just to point out that the two, probably at least two most concerning toxicities here are neuropathy and hypercoagulability or clot. Sedation is certainly a common side effect as well. You have to watch for cytopenias and other things when we use these. So in any case, this is something important. We tend to start patients on minimally on the baby aspirin. We certainly check antiphospholipid antibodies in the SLE population, and we think about whether or not there's any reason to do anything differently in that group. In terms of lenalidomide, so the nice benefit of lenalidomide, which is a thalidomide analog, is that you can see on the bottom there's less neuropathy or thrombosis observed with this drug, and so it takes two of the more concerning side effects not off the table, but certainly lowers that risk. This was a phase 2 efficacy safety study, open label, that looked at a few refractory patients, and you can see 5 to 10 milligrams a day. I tend to start on the lower 5 milligram dose side and watch for cytopenias very closely. Patients were followed a mean of 15 months in this study, and the endpoint was, again, a CLASI activity score of 0, quite stringent. There was an 86% complete response with frequent relapse, so it's a very analogous story to what we heard with thalidomide just a moment ago. It seemed that there was no influence on systemic disease, at least, as an aside, and this is important because we have to think about the rest of the patient and the whole patient when we're using these agents. Particularly for the rheumatologists who are concerned about an SLE patient. The side effects you can see here, the cytopenias, I think, are of particular concern. So moving into actually the one FDA-approved drug that we have of recent for SLE, let's look a little bit into how it fares in the skin. So the mechanism, for those who are not as familiar with belimumab, Benlysta, which is an anti-BLyS monoclonal antibody, is that it stimulates B lymphocytes to develop into mature B cells. The study was of standard of care with belimumab versus standard of care placebo, and the outcome was mean reduction in the Selena-Slide score, which was 37% for belimumab versus 27.8% for placebo at 52 weeks. If you're thinking that that was a sort of a tight spread there, you are correct. And I think for the rheumatologists, particularly in the room who know the story, this was a drug that was sort of just skirted under the FDA sort of approval process, and this, I think, in our hands is not necessarily something I think of as a wildly effective drug, but I suppose has its place in SLE, and we can talk about that. No specific validated measure of CLE, however, and that's probably one of the biggest flaws of a drug that's otherwise meant to really treat the mucocutaneous manifestations of lupus and arthralgias, and it's not meant for nephritis and sort of more serious lupus disease. So it's really a shame for us not to have outcome measures like Vicky's CLASI in this data set. So what do we glean from these studies? You can see here what the rash domain and alopecia domain look like in these outcome measures. And so for those in the back, the blue and the purple represent the active doses of the drug, and the gray is placebo. And so you can see that there is a statistically significant improvement in quote-unquote rash with a slight hint of a dose response over placebo. Alopecia, there was not a statistically significant difference, but you can see sort of a hint at a dose response here. So so from that we can walk away with perhaps some skin efficacy mildly in this drug. This is one I haven't seen presented a lot, but I'll show it to this group. So this was from an ACR meeting in 2011 where they pulled out some of the subsets of, I did sort of a post hoc looking at some of the subsets of this data. If you look at this sort of spidergram here, you have the placebo in gray, the blue and purple again, and you can see out at 52 weeks that the placebo separates out from the drug group in terms of active discoid lesions. So a hint again that there's some efficacy in terms of discoid disease. Again, take it with a grain of salt. With alopecia, a little bit of a dose response and a hint that perhaps things are starting to spread out over more time than just beyond the 6-month point at 52 weeks. Malar erythema, for whatever it's worth, again, not seeing as much of a splay here, whether it's at the 24-week point where you see some split, but then again, not too impressive out at 52 weeks. So a little bit tough to interpret, and again, I think that the weakness here is that we really didn't get a chance to look at a validated outcome measure in the skin, which would have given us some information. I'm sorry, I'm going to pause for a second. I'm just wondering if Vicky, do you agree with those comments for the most part? Yeah. Anything? Okay, I'll let Vicky speak at the end because she can speak much more intelligently about this than I. But we did do a very small open-label pilot study of Apremilast. So for those of you who are very excited about Apremilast for psoriasis or psoriatic arthritis, for which it's FDA approved, it is not approved for the treatment of skin lupus. This was a small open-label pilot study of Apremilast at 20 milligrams twice daily, not the current 30 milligram dose for skin lupus. And I'll tell you that while we showed a statistically significant decrease in the CLASI activity, I would temper it by saying we really ultimately saw only modest efficacy and in a small subset of an already small study. And the patients in this group had particularly poor tolerability from a GI standpoint. So not something that I reach for routinely in my skin lupus patients. So what about new and emerging therapies? So let me take you on a tour. It looks like I have about 6 minutes left, if that's right, so I'll try to be. The only benefit to having too many slides in the deck like this and being from New York is that you find a way to fit the words into the time you have allotted and just talk faster. It's just that simple. So new and emerging therapies. Interferon-inducible proteins. So we know that interferon-inducible proteins are a marker of the presence of type 1 interferons in the skin, and you can see some of those here, MXA and others. And if we look at skin lupus subsets, for example, chronic discoid, subacute cutaneous, tumid lupus, and paniculitis, you can see, and you'll have to, just trust me from the back, that there's pretty reasonable amount of staining here that implies that there is an interferon effect in this disease state. That becomes important when we think about some of the therapies that are coming and that face pathways that would affect type 1 interferons. This is a program from Biogen. The drug is affectionately known as BIP59. BIP59 is an anti-BDCA2 monoclonal antibody. BDCA2 sits on plasmacytoid dendritic cells, and inhibiting it inhibits their activation. And so you can see that this monoclonal antibody inhibits activation in vitro via two mechanisms. I won't go into that in great detail, but ultimately reduces type 1 interferons and therefore other inflammatory players in cytokines such as IL-6 and TNF, and some chemokine production. So certainly mechanistically and theoretically would face diseases like lupus and skin lupus. In their phase 1 data, of which we were fortunate to be a site for their current phase 2 and a proof of concept phase 0, you can see here that there is a look at the both clinical look at with CLE activity measures, but also a histopathologic look at what the skin looked like in patients receiving placebo and then active drug. In this placebo-treated photograph of a subject, you see they have had stable CLE lesions at 4 and 12 weeks, and skin shows MXA expression that's still noticeable. Compare that with a patient who was treated. So this is in the treated subject who showed reduction in CLE as well as skin interferon, type 1 interferon induction in terms of shown by MXA expression in the tissue, where you can see a loss of color here being a good result. So this would be day 1, day 4, same subject. You can see that loss of the pink purple staining shows you a decrease in MXA expression as well as a decrease in CLE score in these individuals. So just suggesting again in the sort of very early stage that this might be an effective therapy, so more to come on this as a mechanism. So what about Rituximab? And again, for the rheumatologist in the room, may be familiar with using Rituxan, sort of second, third line therapy in lupus patients, maybe who have an inflammatory arthritis component, or even for nephritis occasionally, depending on their subset of nephritis and what they failed and such. But how does it fare in skin disease? So this was a study looking at 82 systemic lupus patients who received Rituxan, 32 with significant skin disease before or after treatment. You'll see that essentially the take home here was, particularly among the chronic cutaneous lupus group, that there really, that it was not, I would say, wildly impressive, but so 35% with baseline skin disease had a beneficial skin response at 6 months, 43% had good response with an acute cutaneous lupus, and this includes things like the malar rash, 0 out of 8 with chronic cutaneous lupus. So again, a little bit tempered excitement about Rituxan in that category. What about type 1 interferons again? So we mentioned this at the beginning, and I won't belabor that this is one of the key, we think, pathogenic players in skin disease. So how do anti-type 1 interferon antibodies work in this setting? And so these are slides thanks to Vicky, but Cifalimumab and I'll show you another as well in a moment that were looked at in skin disease, Anifrolumab. So this was Anifrolumab, at least 50% improvement in CLE in patients with CLE activity score of greater than or equal to 10 at baseline. And you can see sort of visually the improvement in this particularly in this one patient. And you can see graphically what that looks like here in terms of percent responders in the active group versus placebo. So, so again, a sort of a proof of concept suggesting that this is a mechanism that certainly could be promising in skin lupus. I mentioned earlier thalidomide, lenalidomide. So it turns out that those compounds, at least as part of their mechanism, seem to bind a protein called cereblon. There's a compound from Celgene, CC220, that is a cereblon modulator that targets 2 transcription factors that sound remarkably like Greek islands, Ikaros and Aiolos. They sound like lovely places to vacation, and play an important role in B cell, T cell, and plasma cell development, and ultimately inhibit NF-kappa B in their path. Again, I won't belabor this. Just to say that there's some plausibility as well, because polymorphisms in these genes have been associated with increased risk of developing systemic lupus, and there are some mouse models again suggesting that these may have a role in lupus, in the lupus state. So how does an inhibitor of this particular modulator fare in an early sort of study? And this is again from Dr. Worth. You can see here again, it's a little tough to see, but the placebo is the right line, the bright red line that's hovering around the 0 change from baseline, and the other lines are a dose escalation of the active compound, and you'll see a little bit of a dose response and some separation from placebo over time in terms of mean change from baseline, again suggesting that this is something that may be worth looking into in a little bit more depth, which is the idea. IL-12/23, and running low on time, so I'll just show you quickly. So we're all familiar, I think, in dermatology and in rheumatology with IL-12/23 inhibitors, particularly Ustekinumab. This was a study looking at that particular intervention in the setting of systemic lupus, but I'll focus on quickly on the primary endpoint analysis, which was of this SRI-4 response, and you'll see that there was improvement in terms of percent of patients with the Ustekinumab group compared to placebo. So just something else to think about. There was a case series published several years ago by our colleague Andy Franks at NYU who showed benefit in subacute cutaneous lupus using this drug. So there's some plausibility in terms of reports as well as what we showed here. And finally, this is filgotinib. There's such a buzz in dermatology about JAK inhibition and all of the things it's going to fix, right? Everything from alopecia areata to initially psoriasis, although that did not move forward with tofacitinib, as you all know, which is only approved for psoriatic arthritis, atopic dermatitis, and here we have a look at cutaneous lupus. So in some ways, being in the upstream and the JAK inhibition space allows for multi-cytokine inhibition, and so from a plausibility standpoint, I think some of this makes sense. And so this is a drug that is being looked at in moderately to severe active cutaneous lupus. It's a JAK1 selective inhibitor, and so we'll have to see how this plays out. But I think there's some intrigue about whether JAK inhibitors and which selectivity ultimately make a meaningful difference in our patients from a lupus, skin lupus standpoint. In terms of classification criteria work, I mentioned a little bit about where we are, where we're headed. We talked about the unmet need in refractory disease. We talked a little bit about the approach to topical and systemic therapy informed by systemic manifestations of the disease, about thalidomide, lenalidomide for refractory disease, sort of second to third line after we failed other things. And then we spent some time on exciting emerging therapies in the space.